It's a pleasure, and I wish to thank all the people not in the room, but Jean-Pierre Delude for running this incredible meeting, Cecilia, without whom I don't think any of us would be here or have things go forward correctly, our Kites and his lovely wife Panchita, and the darling daughter Nydia, if you've not already met her, who are very instrumental to this meeting. And I also want to acknowledge parents of my workers, like Ikro and his wife. So in fact, though I can't speak on the last talk until discussion, I have to say we have some exciting similar data and some new data. We couldn't agree more about the commonality of affective disorders particularly. Now, the natural history of drug and alcohol abuse and addiction are extremely important to remember at all times and to be taught to students in Addiction 101, medical school, which they don't get at education, or neuroscience or other areas. Yes, we'd love to have primary prevention, just say no, but for the most part, it does not work. So we come to the reality of so many people trying a drug or alcohol one or more times. Some will go on to use sporadically and intermittently, and for many, for instance, with alcohol or possibly cannabis, low amounts will be used throughout life. However, when that use becomes a little bit more than intermittent sporadic, we may need to think about in the future having vaccines or medications that can be targeted. And we are now working in my lab, and several others are working on, for instance, an oxycodone vaccine that would not block pain relief from other medications, but which would allow a decrease in utilization of oxycodone. I don't know if we'll be able to achieve it or not. Regular use can go on in some persons, and then when we get to chronic use, and I insist on using the word addiction, which Chuck fought for with DSM-5, we got rid of dependence, but addiction is a very important concept. We then need medications, and we need medications combined with counseling, and access to psychiatric and medical care is needed. 60 to over 90% of persons with any addictive disease will relapse to drug abuse and frequently to the specific drug of abuse if not treated concomitantly with a pharmacotherapy and counseling and other behavioral treatment. Now, currently, since our initial work in 1964 and the first paper we wrote on methadone maintenance treatment in 1966, we have approximately 1.3 million worldwide currently in methadone maintenance treatment, and cumulatively many million have been in and out of treatment. And you see the breakdown between US, Europe, and the rest of the world. Good treatment, Dr. Anchero, we have said for years requires 80 to 120 milligrams a day, and for the last 15 years in the US, because of the extraordinarily high purity of heroin, 150 milligrams a day. And since over 50% have some affective disorder, usually anxiety or depression, though we don't see very, very low schizophrenia rates in US studies across the board. We find voluntary retention in good programs, adequate doses of methadone, adequate access, as the O'Brien group has described, to counseling and other care, reaching 80%, 60 to 80% worldwide. Continuing use of illicit heroin, it's not magic, it's not overnight. If you start methadone or buprenorphine naloxone, it tapers down with time, and that's where your counseling and pharmacotherapy need to come together. But it drops down to 5 to 20% in most programs. What does methadone or buprenorphine naloxone do? It prevents withdrawal symptoms, it prevents craving or drug hunger, it blocks, and I'm not going into this today, but blocks any euphoric effects from superimposed narcotics. And if you use less methadone than 80 mg a day, you can exceed the degree of tolerance developed, and therefore you can get some opiate effect. So it's critical to use adequate doses, and we heard yesterday from Australia, from Dr. Dunlap, that you also need to use the higher doses or highest doses of buprenorphine naloxone to get the adequate effect. Same reason. So the mechanism of action of methadone is it has a very long half-life pharmacokinetically in humans. Rats and mice, 60 minutes and 90 minutes, very rapid. So I write a paper on very rapid opiate, methadone, in rats and mice. But in man, 24 hours for the racemic, 48 hours for the active half of methadone. Buprenorphine, differently, sticks to the receptors. The pharmacokinetics are rapid, but it actually sticks to the receptors. This is important to remember. And therefore, it has a very long duration of action. Methadone is a full mu agonist. It turns out to be probably even more full than Damgo, for those of you that work at the bench. It also, when it binds to the mu-opioid receptor, internalizes, just as does beta-endorphin and the enkephalin, our natural endorphins. Methadone also has modest NMDA antagonist action. NMDA antagonists, like MK801, have been shown to retard development of tolerance. So we actually have two mechanisms which decrease the rate of tolerance development to methadone. They include NMDA antagonism of both the active and inactive enantiomer, and the internalization, rapid, which allows release of the mu receptors to return to the cell surface and function normally. Now, in the United States, I was able to procure the latest information from SAMHSA, from the lady that's in charge of all the latest data in US. Very grateful to her. And right now in US, we have some 330,000 in methadone treatment, 48,000 in buprenorphine naloxone treatment, and 3,700 have received extended release naltrexone. So it's roughly 1/8 on buprenorphine and 1 to 2% on extended release naltrexone, the rest on methadone pharmacotherapy. I had the privilege of going and speaking in Macau, China in April, and it was wonderful there, and I hope my friends from Vietnam, my new friends from Vietnam, will listen to this very carefully. We were able to introduce methadone maintenance in Hong Kong in 1975. That would be when Peter Lee was commissioner, and Bob Newman, along with Vince Stoll, Marie Neisweiner, and myself, introduced it. I visited the clinics in Hong Kong several times. There are now many clinics, as you can see, in Hong Kong, which was thrilling to me to get the follow-up, now that Hong Kong is part of the Beijing government, with 7,000 people in treatment. One of my trainees, Dr. Adelson, who spent 3 years with me and still adjuncted to the lab, was able to help the Macanese government start methadone treatment after it had gone back from Portugal to the Chinese government. And there are currently 2 clinics. They expect to have 5 clinics within 2 years. They have close to 200 patients in treatment. They're aiming for 1,000. They're doing very well. And I will tell you, the Macanese clinic is leading the pack using adequate doses of methadone, which is a failure in most of Asia and much of Europe. So the 80 to 150 a day has been proven to be adequate and maximal effectiveness in Macau. Taiwan, intriguingly, taught by the Macanese. I didn't know they were so close. And they've now got 130-odd clinics, and they have 8,000 people in, 9,000 people in treatment. I have made 12 trips or more to mainland China. I worked through military medicine starting in 1991, and by 2000 we had achieved some methadone maintenance treatment in China, but I was thrilled at the meeting of 450 clinicians primarily to see so many from mainland China, and they now have 167 clinics going, 767 clinics going. They have almost 200,000 in treatment, and they plan to get 1 million in treatment within 5 years. Major problem, again, is they tend to use low doses of methadone, 40 to 80, not 80 to 150. We'll work on that. Now, what are the targets for pharmacotherapies? Well, it's really interesting. We all heard yesterday, you're going to hear in a moment, about dopamine, but none of the dopamine selective agonists or antagonists have been effective in treating any addictive disease. That should be kept in mind. The opioid system seems to be supreme. in regulating reward and also countermodulation of reward. So you see methadone is directed primarily at the mu opioid receptor with a tiny bit of NMDA activity. Naltrexone and namifene, and this is brand new data not published, we know that namifene, published years ago by my lab, is mu antagonist, but also a partial kappa agonist. I will show you prelim of ongoing study where we've shown naltrexone has a similar level of kappa partial agonism in humans, along with its mu antagonism. So both naltrexone and namifene are mu antagonists and kappa partial agonists, and they both are very effective for managing alcoholism. And sorry for Chuck, I don't agree. I think they're totally ineffective, except in a rare small percent, as shown in the US data, for managing opiate dependency. Buprenorphine is primarily a mu partial agonist, but also with kappa partial agonism, not antagonism, agonism, and it also acts at the orphan receptor, the nociceptin site. Now, reward. Reward, dopamine plays a huge role, but how does dopamine go up? Well, compounds that act at the mu receptor will send dopamine up by inhibiting GABAergic neurons, which in turn normally inhibit the dopamine flow from the ventral tegmental area and also the substantia nigra compacta over to the reward area of the nucleus accumbens and associated areas, as well as to the dorsal striatum, cognition, the caudate and putamen. We know that cocaine acts differently. It blocks reuptake of dopamine as well as serotonin and floods the synapse with those two neurotransmitters, but then the mu receptor also becomes profoundly altered. So the mu opioid receptors with endorphins acting, primarily beta endorphin, throughout the brain and peripherally, but also in enkephalin, very rapid acting, act at the mu receptors. But countermodulation, starting in the very early 90s, described by McGinty and her crowd and my crowd at Rockefeller, we know countermodulates each of the drugs of abuse. So if we knock out mu receptors, we get no morphine or other mu agonist analgesia, no heroin self-administration or morphine self-administration, no place preference, that is liking of animals for one chamber with drug as opposed to the chamber of drug. We also, however, see profoundly attenuated cocaine self-administration in animal models and attenuated alcohol self-administration. Countermodulation, very early on. Spangler and my group and Dene and McGinty's group showed that if you gave chronic cocaine or acute cane or self-administration of cocaine by Yasmin Hurd, you see increased dynorphin gene expression, and you also, as Ellen Unterwald showed, you see changes, upregulation of the kappa opioid receptors. Now we see upregulation of mu receptors, but no increase in beta endorphin when we give cocaine. But we see both the dynorphin going up and the receptors going up with cocaine. And Jung-Jeanne has shown in mice, previously shown by others in our group, that if you repeatedly administer or self-administer in a rodent model cocaine, you continue to see this persistent recurrent increase in dynorphin levels. And morphine will also cause, given intermittently, increase in dynorphin gene expression and increase in kappa opioid receptor message, mRNA, and stress. You throw a rat or a mouse into a cold water pool, and you will see profound increase in dynorphin gene expression. And I'm not going to bore you with the details of the epigenetic changes as well as direct genetic changes that are involved here. Stress alone, cocaine, morphine, and alcohol not shown. Now, if we put dynorphin directly into the reward area or the habituation area, the dorsal or ventral striatum, we see, as you see here in the upper left-hand corner, a dose-dependent decrease in dopamine. Nothing. Animals have never seen a drug, neither the rats nor the mice. You get this dose-dependent decrease in basal dopamine level. Now, if you put in a dose of cocaine, as shown in pink, you see a surge of dopamine, and if you precede that with high dose of dynorphin, you prevent it. So the natural kappa agonist prevents dopamine surge. And when we think about strawberries or raspberries, as was talked about yesterday by Anna-Rose Childress, when we think about it, we know our dopamine surges, and the kappa says, you've had enough, don't think about it anymore, get on with your work. But this becomes dysregulated in the setting of each of the addictions. And the lower panel simply shows a natural product, a hallucinogen that we all learned amazingly was not directed at the serotonin system, but solely at the kappa system. This would be salvinorin, and we are now working with Prizensano and Aldrich and others looking at analogs of this compound. And we know if we knock out a kappa opioid receptor in a mouse, you get no response to kappa agonists, not surprising. You get decreased severity of heroin withdrawal, the emotional signs particularly in the rodent. You get increased basal dopamine release. Well, I've shown you the why here. You get decreased affective stress, and you get many other things of interest. Now, we have had the privilege of giving to healthy humans, as well as those with specific addictive diseases, the natural peptide, dynorphin, in 13, not 17 residues, but fully kappa-acting. We humans and non-human primates have the regulation of our prolactin outside the blood-brain barrier. So we can inject into the arm dynorphin, and what we see is the dynorphin acts at the kappa receptors, which in turn act at D2 receptors, dopamine D2, and cause a reduction in dopamine and a surge of serum prolactin, which we long since have published is a very important biomarker of kappa tone in both humans, monkeys, and rats and mice. So here you see a dose-dependent increase in prolactin after dynorphin administration. Well, yesterday I mentioned the stress responsivity, and we know that this cartoon is really important for addictive diseases. Stress and stressors are a major reason for relapse, as well as possibly acquisition. We have two important stress hormones, equally important parenthetically, CRF and arginine vasopressin. At the next meeting in Biarritz, I'll bore you with arginine vasopressin. But they act at the anterior pituitary to cause a surge of release of propiomelanocortin, yielding ACTH, our major stress hormone, and beta-endorphin, our longest mu-opioid receptor agonist. ACTH acts at the adrenal, life-dependent, to cause a release and a, frankly, synthesis of cortisol in humans and guinea pigs, and corticosterone in rats and mice. And the cortisol and corticosterone act in a negative feedback mode, both at the hypothalamus and the pituitary. When this happens, we see a 24-hour circadian rhythm, which I discussed yesterday. We know the mu-opioid receptor normally inhibits this axis, so if we take away using an antagonist, such as naltrexone, nalmefene, or naloxone, we see a surge of these hormones. And it's been shown in a couple of studies in humans, a pure kappa agonist will activate this system. And we see complete normalization during long-term methadone maintenance treatment of the HPA axis, which is profoundly suppressed in heroin addicts throughout their career, and is activated both by alcohol and by cocaine. So if we give a mu antagonist, we see a surge in CRF, we see a surge in beta-endorphin and ACTH, and a surge in CORT. So what are the antagonists that I've mentioned? Naloxone, naltrexone, and nalmefene. In humans, naloxone has no kappa partial agonism, but in humans, both nalmefene and also naltrexone do, and the mu partial agonist, buprenorphine, also has such kappa partial agonism. And for those of you that are into binding, you can see it all here in human cell systems. When we give 2 doses, huge and very huge, of naloxone or nalmefene to healthy humans, as shown in gray, naloxone 2 doses, we maximize the dose, we get maximal naloxone-induced ACTH and cortisol. Look at green. Green is nalmefene, max and supermax, but both a similar release of ACTH in healthy humans and cortisol in healthy humans. And we think this is a combination of disinhibition of mu plus kappa partial agonism. And we went on to show that whereas naloxone does not alter this biomarker prolactin, in fact, nemaphene shows a rise in prolactin, which we studied in a second study to prove it to ourselves in healthy humans, indicating that, in fact, the levels are really terribly important of the kappa partial agonists in reducing dopaminergic tone and causing a rise in prolactin levels. Now, we currently have in progress, and we're about halfway through, a study head-on of IV naltrexone and nemaphene at a 10 milligram dose, a low but maximal dose. And you'll see, not unlike the nemaphene versus naloxone, the nemaphene has even a greater HP axis activation. But when we look at serum prolactin, we learn, not to our surprise at all, that naltrexone and nemaphene similarly cause a rise in this important biomarker of kappa dynorphin tone, and that is a rise in serum prolactin levels, very similar in the two. Now, we know, I've mentioned to you about the fact dynorphin goes up, kappa receptors go up with each of the drugs of abuse, at least the three we're studying most, which are opiates, cocaine, and alcohol. And you see this recurs and recurs. So our group and many others have suggested that a kappa agonist, but that causes some psychotomimesis and dysphoria. A kappa partial agonist might be ideal to treat cocaine and alcohol abuse. So we have been very interested in being able to study agonists, what are called biased agonists, those are ones that act either at the beta-arrestin site or the cyclic AMP site. We are favoring, for this purpose, the cyclic AMP site of action. And partial agonists, which we want the most, and there are none that aren't mixed with mu or with some other opiate target or dopaminergic target, and antagonists. So we're very fortunate, a private foundation has donated money to the Rockefeller University, and we have now synthesized planning backbones, planning congeners, and having a synthetic chemistry group work with us through the foundation. We've had 55 compounds made, which are currently being screened. We hope we have at least one kappa partial agonist. We don't know yet. It's going to take more than 2 years, I think, to find out. But anyway, we're going through piles of brand new compounds never seen before by man. But also, I'm very, very antsy to get going. We and many other groups have proposed that kappa antagonists, pure antagonists, would be good for treating depression, just plain old depression, monopolar. But it might also be good for treating the depressive symptoms or the depression that's concomitant with so many people with addictive diseases to opiates, cocaine, and alcohol. So we are interested in studying a kappa full antagonist. 3 companies had made them in US and gotten them into humans and then backed off because they didn't see a big market. But we've been able to talk one of those companies who subsequently sold their compound to another company, and I don't need to go into the companies, it's irrelevant. They have let me play with their compound, and I'm very grateful to the company who owned it originally, the company that owns it now, and I have my own FDA IND to study this compound, which is a selective kappa receptor antagonist, which the initial company named Opera Kappa. And we've had the study in progress for now 12 months, having gotten an IND and IRB approvals, all of which takes a lot of time in US. And we're studying both healthy people and people with active cocaine dependency and people with early withdrawal from cocaine and people with protracted withdrawal. The study's going along very excitingly. We do many, many measures of depressive symptoms. We do measures of mood and drug effect. We do cocaine craving scales. And all I can say is, unlike the very sad experience of Ivy Carroll and the group at Chapel Hill, who reported in neuropsychopharmacology a rather most unfortunate effect of their kappa antagonists, we have had 0 adverse effects with a large number of cocaine-dependent people and a larger number of healthy volunteers studied to date. And I would love to tell you I see a glimmer of hope with depressive symptoms, but I'm too much of a scientist to let me say that out loud, so I didn't say it. Thank you very much. Kappa partial agonist, kappa antagonist.